AETCM, the Emergency Medicine Channel. Today we'll be discussing a case of a young adult who presented to our ER with complaints of bilateral lower limb pain. Can you begin, sir? So there was this 36-year-old male patient who presented to our ER with complaints of fever, high-grade fever with chills, and along with this he had developed bilateral lower limb pain, but it was predominantly more on the left leg, and pain and swelling was present. And even though there wasn't a proper history as such, but he suspected an insect bite. So it was mostly on the left leg. There were just few lesions on the right leg, but that's about
leg means in the calf muscle?
Calf muscle, sir. Okay, lower one-third of the middle and lower one-third of the calf muscles. Okay. With that history, he presented to our ER. So in initial 10-second assessment, patient was conscious oriented, and primary survey, airway-wise, patient airway appeared patent, and breathing, patient was had a respiratory rate of 17 to 18 cycles per minute, maintaining saturation of 98% in room air. Air entry was bilaterally equal and chest was clear on auscultation. And circulation-wise, he had a heart rate of 88 beats per minute with a blood pressure of 110/70. All peripheral pulses were palpable. Now, disability-wise, he had a full score of GCS and pupils were also bilaterally reactive. And there was no weakness of the limbs as such. Exposure-wise, he was afebrile at present when he presented to the ER, and GRBS was 132 milligram per deciliter. So with this was a primary survey. Okay. And in our adjuncts, there was nothing that had to be like immediately taken because this patient was quite stable. So we moved on to our sample history.
So what adjunct you can try here? Any investigations? Handheld machine can be used in ER, which is available in
CBCC.
Cellulitis is Doppler.
Doppler. We have a handheld Doppler. We can try that if you have any doubt.
So moving on to the sample history, patient's background was he was an established or rather chronic CLD patient, cirrhosis of liver disease, and along with this he had a past history of upper GI bleed. So EVL banding was done about 6 years back, and diabetes, he was recently diagnosed, but he was just on lifestyle modification. He was not in any pharmacotherapy as such. So event-wise, about 2 days back, he presented with major complaints of left leg pain and swelling, and he suspected an insect bite in that area. So following this, he developed high-grade fever and chills. He presented to the ER with these complaints. Now, local examination-wise, bilaterally, edema was present, but it was predominantly on the left leg more, and there was erythematous with necrotic lesions that was seen. Okay. And tenderness was present.
Muscle tenderness
was present, but all peripheral pulses were palpable. No neurological deficit as such was seen. No visible ulcer or foul-smelling discharge. Nothing of that sort was noted in this guy. Systemic examination was pretty much clean. All the systems were within normal limits. It looked like cellulitis, but we had to rule out DVT because even the patient, despite this, he was mobilizing. There's no risk factors as such for DVT in this patient because of no immobilization or recent surgery wasn't there. And background history was that he was a CLD patient. So we started this patient.
What may be the INR in this patient?
INR came out to be 2, sir.
Okay.
2.1.
So he has got any risk because of that? In a patient who is having muscle tenderness, redness, can it be anything related to elevated INR? You may be seeing patient who is having hemophilia or patient on warfarin admitted in ER with what are the musculoskeletal problems they can develop?
Small muscle tear can bleed.
Hematoma is one important reason they admitted to emergency room, especially those who are hemophilia, those who are on warfarin, heparin. So we have seen many patients, they can have a bleed into the joint, bleed into the muscle. Okay, so they can present with that. So you should be very careful when the patient's INR is elevated.
So sample history wise, that was it. So
you have to ask a history of injury previously. Injury means trauma.
So So in our bedside investigation wise, we did a bilateral lower limb Doppler in order to rule out DVT, and it only showed diffuse subcutaneous edema, suggesting more on the lines of cellulitis with no evidence of DVT. And also he had one imperforated uh, vein, that great saphenous vein near the ankle, about 12 centimeters from the ankle. Other than that, so basically early of varicose veins, but no visible venous distension was seen in this patient. So considering his, and then his total counts came in, the total counts was around 10,000 and CRP was elevated, like about
Why
60,
total counts are not
70.
elevated here? You are having a patient who is having infection, CRP is elevated, but counts are not elevated. What
CLD
CLD.
background.
So he is having a chronic immunocompromised state. So CLD patients, even if they have severe infection, sometimes their counts will be very marginally elevated. That also we should be very carefully to be noticed in this type of patient.
So ultrasound was showing more on the lines of favor of cellulitis, no evidence of DVT, and varicose veins. Like I said, the imperforated one near the great saphenous vein, about 12 centimeters.
If the
in
same
ankle.
situation is there in the ankle joint, what else you suspect? Or metatarsophlangeal joint, what else you suspect?
Lower parasitic infection can cause
Gout. Alcoholic patients who come with lower limb swelling, redness, especially in the lower part of the lower limb, then you have to suspect gout also. Here, since it is in the muscle, we are not suspecting.
CRP was elevated to 60, 70, that range, and total comes around 9 to 10,000.
Okay.
So with this, it was a cellulitis. We could have started this patient on gram-positive coverage.
What do you
of
think the reason for
staph?
reason for cellulitis?
Most common is staph aureus, sir. Otherwise,
So you can again divide it
Streptococcus
community acquired cellulitis or hospital acquired
hospital-acquired.
cellulitis. Somebody does not come from an hospital, is not admitted in a hospital. From community is coming with a cellulitis, then mostly it is due to
Staph aureus.
gram-positive coccus, staph or streptococcus. And that staph is very important. But if the patient is admitted in a hospital with history of chronic ulcers, then you have to suspect about gram-negative association, like Klebsiella, Pseudomonas, all these things. Otherwise, most common cause is always gram-positive cocci. Then in gram-positive cocci, you can get MRSA also. Okay. So if you cover like that, it will be very good.
So we could have started at a gram-positive
So
coverage.
what are the
like,
gram-positive coverage or antibiotic you can give?
Penicillin group of drugs, amoxicillin, ampicillin, and with amoxiclav combination,
Amoxiclav,
flucloxacillin for
flucloxacillin.
staph coverage.
Okay.
But this patient was immunocompromised CLD patient, so we suspected sepsis in this patient, which is why we went ahead with a little higher grade of antibiotics,
Okay.
covering even the Pseudomonas aspect also, which is why we started this patient on piperacillin and tazobactam.
Ideally, it is not recommended.
Not recommended.
We have to give gram-positive coverage. What is the coverage of piperacillin and tazobactam?
Along with gram-positive and negative,
It predominantly covers gram-negative.
Negative.
Then it also covers it predominantly covers gram-negative. Then it also covers gram-positive.
Gram-positive.
Okay. But it is not very good drug for gram-positive.
So we also started, like for Pseudomonas coverage and all of it, we started because of his immunocompromised state.
Okay.
If he was a healthy host, then it would have just been gram-positive coverage predominantly. And because he gave a history of a suspected
But
insect bite.
acute skin infection is almost always it is gram-positive.
Gram-positive.
When it becomes chronic after 1 week of treatment or 1 week he has not taken treatment, then gram-negative can come into picture. Otherwise, even if it is community acquired, hospital acquired, if it is an intact skin, then it is mostly gram-positive. If it is a hospital acquired, it can be MRSA, that's all. But gram-negative occurs when there is a chronic ulcer there. Okay.
And because he gave a suspected history of insect bite, he wasn't too sure, but it could have possibly been a mite, a beetle, or anything on those lines. So, which is why we also gave a coverage of doxycycline, not per se for cellulitis, but because he had an etiology of suspected insect bite, which meant to say it can be a mite infection also, which is why doxycycline coverage was also given. Now, then patient was, but we continued mobilization in this patient and dressing was also given. But through the course of the day, or his hospitalization stay, the infection worsened. Like there was
How safe
edema.
will be the mobilization in this patient?
That
You can
again,
analyze. See, mobilization means you ask the patient to walk for half an hour, like
no, just like regular routine, like going to the
just to
bathroom and
prevent
coming
DVT,
back.
he has to do work, because when there is an inflammation, actually we have to give rest for that area. But if you give complete rest, this patient can easily develop
DVT.
DVT. So to avoid that, we have to advise routine activities. We have to ask the patient to walk to the bathroom, like that. Okay.
So pain control was done with
In
paracetamol.
inflammation, most important is rest only. Any inflammation to subside, you have to give some time. You should not use that part. But if you give complete bed rest, then this patient will definitely go to DVT. But he has got advantage that PTNR is already elevated.
So pain was managed through paracetamol also, but we didn't really routinely give too much of paracetamol because of his underlying
How much
CLD issues.
paracetamol you can give in a patient who is having CLD?
Up until 2 grams you can give. Following that, CLD effects it will worsen.
Okay.
So tramadol can be a safer option.
Not CLT will worsen. This patient will go to toxicity.
Toxicity.
Paracetamol toxicity. Paracetamol toxicity in a normal adult it is 4 to 8 grams.
8.
But in a patient who is having CLD, 2 to 4 gram itself they develop toxicity depending on the severity of the liver disease. So paracetamol, if possible, you can avoid.
So tramadol can be our other option, but when we're giving tramadol, we have to ask about the patient's seizure history, and also patient can have vomiting tendencies. So antiemetic should also be supplemented when we're giving a tramadol injection. Then that is how we control the pain aspects. And sugar levels, even though he was like diabetic, considering his septic state, hyperglycemia can be increased. So we maintained a target between 140 to 180. So that is how we achieved
What
pain
you
and
started?
glycemic control. On this patient consistently just had 132, 142 glucose. So we didn't really have to supplement anything. But if at all it goes up, we can give human insulin, like Actrapid can be given, short acting. Insulin can be given to maintain this range of sugar. And then regular dressing was done with glycerin and magnesium sulfate, and proper limb elevation was provided for this patient to reduce the edema. And when the patient's infection, or rather the local examination, when we kept doing it, we found that the infection had increased or rather worsened. So at that point in time, his mobilization was restricted, and proper limb elevation with regular dressing was done. Now, in the due course of time, blood culture reports came in, and that showed Vibrio cholera non-O1, non-139 strain.
Okay, that is diarrheogenic.
Diarrheogenic.
This is not diarrheogenic.
The thing is that it has the capacity to cause both gastroenteritis and septicemia, but it is mostly a colonizer even in present and healthy host. So patients can have asymptomatic period also, but if a patient is immunocompromised or has an underlying liver disease, then this can cause extensive infection leading to septicemia and is also associated with high mortality.
Okay.
So otherwise this strain is not as risky or
virulent as
the
routine
other
cholerogenic type.
Yeah, that is the O1 strain.
Okay.
And it can cause gastroenteritis, but this patient did not give any history of gastroenteritis, but he had wound infection. So that came positive for Vibrio cholera, and it was sensitive.
Another common organism, Vibrio vulnificus, like this, that also can produce severe cellulitis, infection, septicemia in patient who is having immunocompromised state, especially alcoholics.
And near seawater, seafood, they are more prone or susceptible for these strains. Now, this particular strain is very sensitive to tetracyclines.
Okay.
So, since we had started it for early itself for mite probable infection for insect bite, it kind of helped for this.
They started doxycycline.
Doxycycline we had started earlier itself.
What is the dose of doxycycline?
100 mg we give BD for 7 to 14 days.
What is the routine ideal prescription dose of doxycycline?
200.
200 loading dose, 100 milligram OD.
OD.
But most of the doctors give 100 milligram BD. Okay.
So doxycycline was initially itself started. So when sensitivity report came in, this patient was sensitive to tetracycline. So we continued on tetracycline, but we also added fluoroquinones because this patient had worsening local wound infection.
Okay.
So then, and the CRP kept increasing, which is why, and the Spiptas was resistant to Vibrio strain. Generally, Vibrio strains are not very susceptible to penicillin group of drugs. So Piptas was withheld and meropenem was started because his urine also suggested significant growth of Acinetobacter baumannii, and that was sensitive to meropenem. So we had to cover both UTI related infection and also the septic part of the wound. So he was hiked up to meropenem and ofloxacin. That is what we added, and we continued on doxycycline for a while. And then through the course of period, because of the regular dressings and restricted mobility and also limb elevation with high coverage of antibiotics, his infective parameters went down.
Okay.
Then, in view of high INR, FFP transfusion was done even though he had no bleeding manifestations, and then INR was kept in check, so it was brought less than 2, 1.6 to 1.7 range is what we kept this patient's INR, and then CRP came down to around 40-50 range from 80, and
What is the
otherwise
fibrinogen level?
384.
Okay. Is it good or bad?
Fibrinogen level, if it goes down, DIC can
DIC
be
chance are
chances
high.
are there.
Here it is high. Why it is high? Fibrinogen is like your CRP. It's a acute phase reactant. So any inflammation, fibrinogen will definitely increase. But if it is coming down, you have to be very careful. If it is less than 100, then the patient is going to DIC. This type of patients will, if you don't treat properly, they'll go to DIC.
Yes. So PTINR APTT was like 43.3 APTT, and fibrinogen we transfused FFP.
APTT is increased or normal?
43.3 is increased.
Increased. So that means two parts of the coagulation system is affected. But the main part is that is a final common pathway. That is fibrinogen. That is not affected. But if you don't treat properly, initially itself with good antibiotics, this patient will go to DIC. That can be picked up by the fibrinogen level. If fibrinogen level is also low, how do you treat? So PTINR is elevated, APTT is elevated. Both intrinsic and extrinsic pathways are affected. But if
Cryoprecipitate.
then you have to give cryoprecipitate. FFP with cryoprecipitate. That is a treatment for DIC. Okay. What happened to the patient?
This patient, through the course of his week stay in the hospital, he gradually improved. CRP came down, and at that point in time, when we placed a consultation for plastic surgery for further management, they weren't too keen on the idea for debridement. Generally, debridement can be done, but this patient wasn't really an ideal candidate because debridement will cause further seeding of organisms deeper into the tissue. So it will further worsen the patient's condition. So he was just conservatively managed with regular dressings, limb elevation, and restricted mobility with high antibiotic coverage. Then through the course of
he does not require high antibiotic only because of this cholera. He was started on high antibiotic because of the Acinetobacter, not because of this one. This cholera, what is the treatment?
Tetracycline.
Tell what is the newer tetracycline approved by FDA? Okay, so that is the latest tetracycline approved now. Okay, but here it is not in India. It is not available. We have doxycycline.
When the infective blood parameters showed a decreasing trend, he was de-escalated and finally just put on fluoroquinolone. That is, tablet ofloxacin was given in a dosage of 400 mg.
He is having ascites?
And ascites he didn't have, like minimal ascites itself, but he was not really like, but decompensated CLD because he's had history of upper GA bleed in the past.
Okay, suppose he is having ascites, what antibiotic you will continue in this patient?
A gram-negative coverage.
So you have to give SPP prevention. What is the treatment protocol?
Again, fluoroquinolone.
Which fluoroquinolone?
Norfloxacin.
Norfloxacin. So you give 400 milligram once daily to continue. Okay. But here this patient does not have an ascites, so we don't need to continue it. How long you have to continue the treatment for cholera? Cholera, as such, we know it is only for 5 to 7 days. Even single antibiotic itself can kill all the bacteria, but routinely we give 5 to 7 days. But here, since the cellulitis part is still active, you have to continue the antibiotic till the cellulitis resolves. Okay, because otherwise again he'll come back with the next episode of cellulitis with some other bacteria. Okay, what antibiotics can be given as prophylaxis for repeated cellulitis? This is nothing related to this topic. You get many patients who is having elephantiasis. They repeatedly come with cellulitis. Diabetic patients who come with repeated cellulitis.
DEC.
DEC is not. DEC is a choice only in a elephantiasis. So that is a treatment, prevention. Oral penicillins. Oral penicillins we routinely give Pendits. Pendits is a 400 milligram OD. That is a drug used for rheumatic heart disease. So same antibiotic can be continued for prevention of cellulitis. So many patients will get benefit because of the continuous prophylaxis. So they don't develop gram-positive cocci infection, but still they can have a gram-negative infection. Okay, this patient is discharged.
Discharge.